Hi there, and welcome to the Trauma-Informed Care and the Long-Term Care Organization video series. The topic of this webinar is the MDS and the Behavioral and Emotional Critical Element Pathway. My name is Paige Hector. I am an advanced practice social worker with almost 30 years experience in the post-acute and long-term care setting. I have passion around a lot of different topics, including, of course, trauma-informed care, process improvement, and overall clinical operations for the interdisciplinary team. I write columns for two well-known publications, and I am involved in multiple national work groups and committees. My bio is available at the end of this presentation. Here's a list of the video series, and we are talking about number 6 today, about the MDS and the CE pathway. In today's topic, we'll be talking about, again, just a quick overview of the sources of trauma, triggers, and then we're going to spend a little time on neurocognition and why that's so important, the correlation with the MDS, and of course, the critical element pathway. As I began working more in this area of trauma-informed care, I was thinking about some questions, and I put a couple of those prompts here on the screen for you to consider. What is it that how can you integrate trauma screening into your daily workflow? But the caveat there is without adding additional tasks. What are staff already doing that is providing valuable information to support trauma screening? As I pondered those questions and really thought about how nursing homes work and all the information that we gather and all the data that we use, I came up with two possibilities. One of them is the MDS. The second one is the critical element pathway for behavioral and emotional status. Before I delve into those, I want to just do a quick reminder of the sources of trauma, triggers, and re-traumatization, and how those topics are instrumental as we begin to think about what is it we're already doing in our nursing homes that supports trauma screening. So once again, there's potential sources. There's so many potential sources of trauma. Any type of abuse or assault, neglect, poverty, and homelessness, attachment injuries, many different losses, growing older, aging, loss of function, bullying, shaming, generational trauma, loss of relationship, natural disasters, war and torture, but also to consider witnessing any of these. So we can begin to think about what are we already doing, that while we don't have to ask specifically, have you had any of these experiences, there are ways that we are interacting with residents, observing residents, talking with family members and staff that will give us information that might give us clues to experiences of trauma and how they're impacting the resident currently. Specifically, sources of medical trauma. There are many different ways, and this is hard sometimes, as I've said before. You know, it's really difficult because as staff members, we are generally some of the most compassionate and caring and purpose-driven people that we come to work with the intention to help and to alleviate suffering and to bring more comfort to people. So sometimes it's really hard to believe or maybe even appreciate how some of the things that we do in a medical type setting can actually trigger people or even re-traumatize people. So in terms of aging and illness, you know, we see this every day in our nursing homes. People that are in our communities, perhaps following an acute care episode or needing some rehab. Perhaps they are living with a chronic illness or living with dementia, and they require the level of care that we provide in our nursing homes. They need help with daily living. They can no longer manage finances. Perhaps they've experienced the death of a partner or a spouse, health and cognition changes. There's so many different things and losses related to aging and illness. So all of these are correlated with the things that we are already doing, the questions that we're already asking residents. And I'll make that connection in just a moment. Keeping in mind, too, that institutional environments, like a nursing home, can at times feel dehumanizing. Sometimes we have rigid routines. As much as we like to think that we're providing person-centered care, there are things that we do in our nursing homes because there is a need for us to be efficient as possible. So some of the things that we do can feel upsetting to residents or dehumanizing. Loud noises, interference with sleep and privacy, physical illness and fear of death, and little control over who touches them and how. Some people may experience distress, but not an experience of trauma. Conversely, some people have experienced what we could really define as a trauma level event, but not have any distress at all. So it really does indicate that our experience of trauma is very individualized. It's a perception. So when we're talking about trauma, it's more important to understand what the trauma means, what the experience means to the individual, and not so much exactly what happened, but how we perceive, how we experience it, and how it affects us in our current situation. So a trigger can be anything, a smell, a sight, an emotional state, anything at all in our current environment that literally can transport us back to and almost relive a traumatic experience. That's what we call re-traumatization. Some of the potential impacts of trauma in multiple different domains. So emotional regulation up here at the top, control impulses, difficulty with controlling impulses, interpreting emotional cues, and difficulty establishing or maintaining trust. Trauma can impact our cognitive functioning, our ability to form memories, to learn and concentrate and make decisions, to process information. It can impact our ability to have healthy, trusting relationships, expressing our needs and wants. Setting and upholding boundaries is a huge thing for some people who have experienced trauma. Our perceptions and beliefs. If you just think about the pandemic, our core beliefs about others, about ourselves, about our general safety in this world and our ability to hope. For some people who have experienced trauma, and I think to varying degrees, we've all experienced stress, of course, related to the pandemic, but for some people, it's really shattered our sense of safety and about our world and our ability to move forward and to hope and to recover. Physical and mental health. People who have experienced trauma, the research clearly shows that those individuals are at higher risk of developing a number of different conditions, higher incidence of substance use and suicidality. I really like this visualization that the consequences of lifetime exposure to violence and abuse. Look at all these different areas that it can impact. So I want you to start thinking about all the different screening tools, your assessments, the history and physical, the list of diagnoses and illnesses and things that our residents are living with and dealing with. Look at all these different categories and begin to think about, could it be related to trauma, to an event of trauma in their past? The neurocognition, which is really basically how our brain functions, is directly impacted by an event or an experience of trauma. And one of the most important things in our nursing homes and long-term care environments is a neurocognitive examination, which can provide critical information, not only to support the individual, but to support us as staff, to learn how to support the person in the most effective way. For example, a neurocognitive assessment can give us important information about which parts of the brain are intact and which ones are maybe struggling a bit. So a person's ability to have critical thinking skills and problem-solving skills. So it helps us understand as staff, where might this individual need some more help and support, and then how do we go about providing that support to them? So let's take an example of a stroke. How does the stroke affect the ability for this individual to regulate their emotions, problem solve, and form healthy relationships? So, of course, in your experience, you've had many people either come through your community, your nursing home for rehab, or perhaps they live there who've had a stroke. And each one might be slightly different. I remember in my career, I've had many people with strokes that, some people had expressive or receptive aphasia. Some people could communicate effectively, but could not control their the emotional regulation ability was diminished because of the stroke. So understanding, in this example of a stroke, of how the stroke affected that person can help us as staff to know where best we can intervene to help support the individual. So in the event that they are triggered, that something in the environment triggers them and they are now in a fight, flight, or freeze response state, what do we do as staff? If this person's ability to problem solve or to regulate their emotions has been impacted by a stroke, what then can we do? So that's the importance of a neurocognitive evaluation, to help give us that really important person-centered information to help us engage with this person with a trauma-informed care lens. Without this information, we might try to do things to intervene or to support this person that cannot be well received or effective for that person, because that part of their brain is not functioning as a person with not a cognitive limitation might have. So we need to understand how the trauma in this event, example, a stroke, has affected their ability to function. To me, it really comes down to critical thinking, and that means reasoning. Critical thinking is the ability to reason. So the ability to take in all this information. So in this particular segment of this video series, we're talking about the MDS. Looking at all the information that we gather when we do that entire document, 40-some pages long, and all that information we gather, the ability to think critically, could any of this possibly be related to trauma or a symptom of trauma or being triggered by a trauma? So I'm going to invite you to think about the MDS in a whole new way. So as you all well know, there are 18 sections on the MDS, and many of them could be related to a trauma history, a symptom, or trigger a feeling of re-traumatization. So as you go about completing whatever sections of the MDS you complete, start thinking about those sections with the trauma-informed care lens. At the same time, I don't want us to make the mistake of assuming that the presence of those conditions or situations automatically indicates trauma or distress, because like I said earlier, it's all very individualized. My perception of this event could be very different from your perception, or my experience with the medical diagnosis could be very different from another person's experience. So just briefly, what I did was I went through the entire MDS line by line, and I thought to myself, what are all the different ways that a person could either, who is experiencing, for example, in section B, hearing, speech, or vision limitations, obviously that could be very much associated with trauma, a trigger, trauma reaction, or some kind of a source of distress. If I can't hear or communicate or see properly, that could absolutely contribute to my feelings of panic or overwhelm or confusion. Could be related to a medical diagnosis. So you can see how all of these things are interconnected. Cognitive patterns in section C. For an individual, difficulty hearing and seeing and communicating or understanding the environmental cues could absolutely be experiencing trauma related to that, or it could be directly related to a trauma event from their past. So delirium, very clear research that indicates that trauma is a very clear indication of post-traumatic stress disorder when it's coupled with delirium. Delirium, trauma, and PTSD are very much related. And of course, every section here, I won't go through all of these on this slide, but each one of them can be directly related to trauma. So I went through sections F, G, and double G. So when we have people with experiencing customary or routine changes, you know, for the individual that says when you ask the questions in section F, nope, not important at all, or important, but I have no more choice. I can't do them and I have no more choice. I want us to start thinking about, wow, could this somehow be related to anxiety or stress? Because if they're no longer able to do the things they used to do, or they no longer feel like they have choice, those could be indications of some relationship with a trauma or trauma experience. The need for assistance with any of the activities of daily living, dressing, bathing, grooming, hygiene, all of those certainly could be correlated with trauma. So we have 2 more slides here. So you can see here, every single section of the MDS can have some relationship of trauma, a trigger, or a reaction, or some source of distress. Even if the individual does not describe it as an experience of trauma, begin to think about how all of these things might add to a person's distress, how that might be related to expressions of distress, of anxiety or depression, or calling out, or addictive types of substance use behaviors. So I just want us to expand our way that we think about these things. And again, here is the slide 4 of 4. I want to just point out here, look for a moment, restraints and alarms. And I fully realize that many facilities have gone restraint-free, which is fabulous. But even an alarm, the best of intentions, sometimes we use alarms. And I think that a lot of facilities have gone away with that. But even something, an alarm, a bed alarm, a chair alarm, a wheelchair alarm, as a person gets up and that alarm is set off, could be a very traumatizing event for an individual. So all of those are areas. So as you go through the next time you do your MDS, begin to think more broadly about those. Keeping in mind, too, a lot of things that we attribute to or medicate as signs of aging could actually be signs of trauma. So I give you a list here. When people have variations in how much they eat or drink, cognition changes, their sleep habits or sleep patterns change, socializing, activity, and anxiety, all of these things could be related to trauma or re-traumatization. Now, the other part I want to talk briefly about here is the behavioral and emotional status. This is the critical element pathway. So if you are not familiar with this document, or maybe you're not using it, but you've heard of it, I strongly encourage you to take a look at these. This is one of 40 protocols from the Centers for Medicare and Medicaid from CMS. And the purpose really is to assist surveyors to determine if your facility meets regulatory requirements for a specific care area. Now, like I said, there are 40 of these, we call them critical element pathways or CE pathways. They're available. You can download them at the exact document that the surveyors use. You also can use in your facility. For example, there are CE pathways for communication and sensory problems, dental status, hospice and end-of-life care, pain recognition, pressure, ulcers and injuries, neglect. So this particular CE pathway is behavioral and emotional status. And on that worksheet, and that they are rather extensive, and I can appreciate how some staff, it can be overwhelming to use these. But if you can at least look at these as a possible tool to help us, to support us in our adopting trauma-informed care principles and practices, there are 2 questions on this particular CE pathway. Number 1, did the facility provide appropriate treatment and services to correct the assessed problem for a resident who displays or is diagnosed with a mental or psychosocial adjustment difficulty, or who has a history of trauma or post-traumatic stress disorder? So that's the first question. So the way that I see this could be used to support all of us is that even if we use that as a prompt, and I'm going to give you a slide on the next slides to where might you look in the medical record to determine if we've accomplished this or not. The second question on this particular pathway, did the facility ensure that the resident whose assessment did not reveal or who does not have a diagnosis of a mental or psychosocial adjustment difficulty or documented history of trauma or PTSD does not display a pattern of decreased social interaction or increased withdrawal, anger, or depressive behaviors, unless it demonstrates that such patterns are unavoidable. So what we're talking about here is making sure that we are using our critical thinking skills to look at the residents and their the way they interact, the changes and conditions they might have, their mental and emotional well-being, and really think about, is there something happening in this person's life that might indicate that there's a trauma history or something that's happened that has traumatized them in such a way that they've experienced changes. So as you go about reviewing the medical record, here are some of the ways, the areas that I would recommend that you take a look at. Obviously, the care plan. Take a look at the care plan and all the different areas, the areas of need that you might have identified as areas to watch out for, to intervene with. Interdisciplinary notes, and I really do mean interdisciplinary, social work activities, dietary, nursing. Take a look at the H&P, the physicians or the medical providers' progress notes, flow charts from the CNAs and documentation, therapy notes, and all sorts of consultations, because the richness of the records that are available to us to take a look at with the lens of trauma-informed care, there's so much information. Further supporting this is FTAG 842 medical records, which states that in accordance with accepted standards of practice, this is from the guidance to surveyors, that the medical records shall reflect a resident's progress toward achieving their person-centered plan of care, maintenance, improvement or maintenance of clinical, functional, mental, and psychosocial status, medical and non-medical status when a change of condition occurs, and that the record must reflect their condition and the care and services provided across all disciplines, and furthermore, to facilitate communication. You know, in all of my career, I've looked at the regulations so many times. In fact, right here in my office on my desk, I have the entire state operations manual, constantly taking it out and looking at the guidance to surveyors, because there's so much really great information in there. So I'd love us to see the regulations as not something that we just have to adhere to, but actually something that can support us. And there are lots of clues and information within those regulations, and specifically the guidance to surveyors. So I hope this very brief video has given you some information to reconsider how you look at and operate and do the MDS, as well as consider using, if you're not already, the critical element pathway for behavioral and emotional status. As I am ending all the videos with, is encouraging to think about how might you use this, or what ideas might you have next to investigate, golly, how do we do the MDS in our community? Might we use that in such a way to help support us to carry out trauma-informed care and to reconsider how we do trauma screening? Thank you for the time that you've spent with me for this short video. Here is my bio available, and also just to give thanks to the sponsorship of the Care Compass Network and the Finger Lakes Geriatric Education Center for making this video series possible. Thanks so much, and I'll see you on the next video.